Top Med Talk.
Hello and welcome to Top Med Talk Down Under. I'm Kate Leslie and I'm here with my co-host Andy Cumpstey at the Australian and New Zealand College of Anaesthetists and Faculty of Pain Medicine annual scientific meeting in Cairns in beautiful far north Queensland in Australia. We've had a great meeting so far and we've had a terrific morning. We just had some more great plenary sessions, and then we've just been to the Clinical Trials Network Breaking Trials session. So we're going to be talking to some of them tomorrow, I think, Andy.
That's right, tomorrow, Kate, yeah. And it's always amazing sessions here, both in the main auditorium but in all the separate rooms around, lots of smaller sessions going on as well. But I think for me, there's also all the things outside the sessions. As we came out of the Breaking Trial session there was a mountain bike session this morning, there was yoga going on this morning, there was fun running this morning, and as we came out of the Breaking Trial session there's people waving lightsabers around learning to be Jedis. I've never been to a conference where that happened before, but I guess come to Australia, be an anaesthetist and learn to be a Jedi. And
then we always have lunch in our healthcare industry reception area, and we're looking down there now and they're eating high protein, high vitamin, high energy food to keep them awake this afternoon.
But straight away that brings this big kind of friendly networking, isn't it? Everyone sitting there eating lunch but catching up with old friends from previous meetings, but also from around the world, making new contacts and new networking. It's a great place to be. Come to the conference.
Yeah, it is. And it's such a great conference that we attract the editors of all of the major anaesthesia journals to the conference, which is fantastic. And they come here because of our great research, I think, but also because it's a fun place. So on that note, we've got Matt Wiles, who's the editor of Anaesthesia. Matt, welcome to the podcast.
Hi, thanks, Kate. It's great to be back again at the ASM, having another great time.
And tell us about your role in Sheffield.
So I'm split mainly half between the journal, and my clinical work has decreased a lot, but now it's mainly focused on trauma. So I'm the clinical lead for our major trauma centre, and all my clinical anaesthetic sessions are either as one of the major trauma consultants or doing the trauma list. So that's pretty much where I live at this moment in time.
Keep you on your toes?
It certainly does.
And we've also got Catherine Downs, who's a specialist anaesthetist from Sydney in Australia. Welcome, Catherine.
Thank you.
And what's your role at Prince of Wales and the university?
Well, I'm a senior lecturer at the university, but I'm a clinician at the Prince of Wales, where I do both cardiac anaesthesia and obstetric anaesthesia. So I've always had an interest in critical bleeding from many an event through my 25, 30 years of work. And I was responsible for the introduction of viscoelastic testing to our campus. So it's a 4-hospital campus. It's got the Prince of Wales, but also the Sydney Children's Hospital and the Royal Hospital for Women and a private hospital as well. So getting everybody communicating and on the same page and doing the same thing, and introducing a technology that's tricky to use in the middle of a critical bleed. So that's been my real interest.
Terrific. So we might start with Matt and learn about how to lose blood and how to identify we've lost it, and then get on to how to test for it. So Matt, you're going to give us a great update on major hemorrhage and trauma, I think, later on in the conference. Can you give us a preview about what you're going to say?
Yeah, absolutely. So major traumatic hemorrhage is a big problem for all of those who work clinically there. So it affects about a third of our major trauma patients, and it's one of the big mortality outcomes. If we take out traumatic brain injury and the sequelae of that, then uncontrolled massive hemorrhage is the major cause of death. Lots of work we've seen over the last 20 years. I started in the dark old ATLS days of lots of crystalloid and not doing much else, to where we are now with the work Catherine's doing with viscoelastic testing. But it was quite interesting writing the talk for this one, when you actually go through and try to, I always feel as an editor-in-chief, you've got to provide an evidence base. So you go and drill down and look at all the studies that have been there that underpin our current practice. And then you realise that it's not very good at all. And that nearly everything has shown no benefits in mortality, limited benefits on some coagulation-based measures, but we're not really showing huge changes in mortality. And you think, oh, how can this be the case? Because this is cutting-edge 21st century stuff. And then I reflect back on my previous life as a neurointensivist, and I've seen all this with traumatic brain injury. And as an intensivist, I remember this in the 1990s. I'm sure, Kate, you remember all the ARDS trials, when we spent ages looking for magic bullets, single interventions that were going to make a big mortality outcome difference. And they didn't. Nothing did. And then you look at, if you drill down into disease, you realise that trauma is not a disease state. It's hugely heterogeneous. So we know that chest trauma is very different to abdominal trauma, blunt and penetrating, again, have very different outcomes. We've now got a completely different population. So we've got an ageing population, but an ageing active population. We had someone at work at 75 who injured themselves parapenting the other day. I mean, this didn't happen 20 years ago. And needless to say, of course, he was on clopidogrel and a DOAC, because everybody is nowadays. So a lot of the evidence doesn't reflect our population and doesn't reflect the differences that we see in terms of injury patterns, severity, and all the sequelae that come. And mortality is often determined by a huge number of factors. And, a lot of our intensive care colleagues will probably say it wasn't the initial insult that caused the problem, it was sequelae. So the challenge then for clinicians is, how do we tease out the trial evidence that looks equivocal, but we know when we use it clinically that it can make a huge difference?
We spoke with Nadine Attal the other day, the pain medicine visitor, who was talking about personalised medicine in chronic pain, and she made exactly the same point, that for each intervention there are people who it's going to work in and people who aren't. Where it won't work. She talked about pregabalin having a number needed to treat of 8. So the same thing goes for blood. We need to tease out the population who are actually going to benefit from receiving blood products.
Absolutely. I mean, there's going to be a huge genetic component as well, over and above a lot of things. And we look at some of the biobank work that's been done for all these, genetic markers, and you feel that the next big step in individualised patient care is going to be some form of genetic-based signalling. We could have our tests done at some stage in our life, and I then know my coding that says, actually, I'm someone who will benefit from X, Y, or Z, and get very personalised medicine. At this moment in time, we have to provide a broader-based, non-individualised approach on the basis we won't miss anyone. So we're sort of sacrificing specificity in order to avoid missing someone. And I think that's an important thing to recognise when we look at the evidence, that we're trying to do the best not to miss people until we can do something truly bespoke.
And I think it's worth highlighting the differences in giving the blood as well. I mean, we talk about giving blood, but obviously there's red cells, there's the yellow pack, there's the cryo. But I mean, blood's got so many different functions and physiological reasons as well. I mean, in my world, oxygen capacity, oxygen carrying consumption, there's a whole load of research going on now about synthetic oxygen carriers, which I don't think it'll be too long before we're giving those instead of red cells. But obviously that's not going to give any coagulation benefit. So it's not just a case of, the patients are different, but our treatments are so heterogeneous as well and doing so many different things. Does that feed into any of the work that you've been looking at in the trials?
Hugely. I think the other thing that we've seen, and it's been well illustrated, I just went to an excellent retrieval talk, because obviously that's far more advanced in Australia than it is in the UK, where you can find a trauma centre in about 90 minutes, wherever you are. But we're now doing more and more interventions at the roadside, and the ED starts in a lay-by on your road, and some of the interventions that are happening. So the interesting factor there will be is, actually, if we get there sooner, and almost always in medicine, the quicker we do an intervention, the better the outcome, is starting treatments a lot earlier. The bad old days, it was 6 hours before you got any form of red cells. Now you could have some fibrinogen concentrate, some red cells, an arterial line before you even hit the ED. So I think that's potentially a very exciting area of the temporal effect of interventions as well.
So I guess that segues nicely into the temporal effect of the testing. So I mean, traditionally we've obviously focused on coagulation testing going off to the lab and coming back a few hours later, but increasingly point of care testing is the way that we're all going, isn't it? So Catherine, don't you maybe give us a quick summary about some of your work on that area, and for people listening at home, what the different point of care tests might be and how we could use them?
I guess for people listening at home, the point of the point of care test is those that are medical will know that we will transfuse red cells based on a hemoglobin, which is something we can easily measure at the bedside or with a blood gas. And there's also a whole lot of yellow products, as you mentioned. And traditionally, we just throw a whole stack of yellow products at every patient, because that's better than having nothing, which is what we had when I started out.
And yellow products are platelets and...
Platelets, plasma, cryo, and some lyophilized products, and what therefore is clotting. So rather than just giving hemoglobin and fluids, we're now, of course, realizing that you need to give something to help the blood to clot. But not just everything to help the blood to clot. Sometimes you don't need anything, particularly, so my interest is cardiovascular obstetrics as opposed to trauma, much more homogenous group of people. Commonly in obstetric hemorrhage, you give red cells and some crystalloid and a uterotonic or stop the obstetric bleeding in some way. You don't need any clotting products because the pregnant woman is designed to have a higher level of fibrinogen and to clot quite well. So throwing a whole lot of yellow products that can cause cardiac overload at those people is really increasing their complications, costing money and not benefiting them in any way. And similarly in cardiovascular surgery, there's more evidence than other areas, and I think that's because it's a homogenous group of people, and they bleed a lot of the time and they're similar, so therefore you get better compliance with the algorithms and people familiar and not so cognitively overloaded with it all.
So what testing are you now doing in Sydney to help target that then?
Yeah, so here in Australia we have, there's two main ones in use. There's a few others coming in, but the two main ones are ROTEM, which is from Europe, and TEG, which is more commonly used in America, and both of those systems are used in Australia. So what I'm interested in is why are there all these RCTs that can't show something that we know on the ground to be true, or only show it very slightly? And it's about the cognitive overload and the translation of the evidence to the people. And so trying to make it simple. So I was tasked last year to speak to the haematology trainees and haematologists at Lifeblood Red Cross nationally and do some education. They're realising that their juniors coming through need to understand point of care hemostasis. And so I developed, in consultation with lots of colleagues, an algorithm that has both TEG and ROTEM and is step-by-step thinking about tranexamic acid and then fibrinogen and then step-by-step in terms of what's most likely to work and walking your way through it so that you're not so cognitively overloaded. And so that if you're learning it, imagine our trainees going from hospital to hospital with ROTEM 1 minute and TEG the next minute. And some hospitals have got both technologies in the same unit because there are certain strengths of ROTEM in obstetrics being very accurate on the fibrinogen, but then TEG's got a module for platelets, so you can pick the clopidogrel that you were talking about before without having a separate multi-plate machine, which is what we have.
So Matt, maybe coming back to hips then, ROTEM and TEG in hips, is that the way forward?
I think probably the most useful thing there, we do get some blood loss, inevitably. Everybody loses a couple of units, and often that's a population that starts off peri 100, 110 at best. I think the real benefit there will be, can we identify the patients in whom we should wait for clopidogrel to wear off, and those who are on a DOAC, what is the sweet spot for going? Now, that lands into the whole debate of general anaesthesia versus spinal anaesthesia for neck of femur, which I generally don't get into.
Very wise, I think.
Yeah, I think local practice probably top trumps most things, and we are, in Sheffield, we're a spinal-based unit where possible, and people will be deferred for at least 24 hours if they're on a DOAC, particularly with low renal function. However, in some people that won't be long enough, and in others that will be too long. So we don't have access to these things at the moment. I think the ability to do that at the front door and then at 24 hours and to say, actually, we don't need to give anything to reverse it. We can just crack on, or if we're going to do them today, then we should just do a general anaesthetic and bear in mind, they're likely to bleed. Again, that sort of individualised and based medicine.
And again, bringing your point earlier, which is an excellent point about care moving out of the hospital, particularly in Australia, but increasingly around the world as well. I mean, how far off are we being able to use these sort of testing kits at the roadside under a plain wing? And is that on the near horizon, or is that still miles and miles away in the future?
I mean, they've been using the point-of-care INR testing, which is pretty good for trauma-induced coagulopathy. So if you have an INR of more than 1.3, then that's got about an 85% specificity for the diagnosis of trauma-induced coagulopathy.
Right.
So I think if you were a pre-hospital physician, you can do a single nice and quick point-of-care test. It does come back in a matter of moments. That would let you know whether you should give your fibrinogen concentrate, which again, as you alluded to, Catherine, you don't want to give any treatment that you don't need to at this moment in time. So I think things, I don't know where things are at in terms of pre-hospital full rota, and that sounds
Not
optimistic.
really, but a point of care fibrinogen test is what's in development and what we would like to have. Something small that you could take. The Rotem and the TEGs are like a computer, so I'm not sure there's any plans to have them on the plane. But if you could just know the fibrinogen, then you've got your first step done, and then you get to the hospital in time to check for the second step in the algorithm.
So, in terms of implementing your program at Prince of Wales and the campus, what challenges and barriers did you encounter to getting all of the players on side?
It's a fascinating topic, isn't it? Humans. And they're all so different, and humans don't like change because I've got this, and it's really interesting how some subgroups, I actually find anaesthetists far more keen on adopting new things.
That's interesting.
And intensivists quite, but I've got this, Catherine. Do I really have to learn a new thing? Well, yes, actually you do. But don't worry, we can talk about it again next week and not give that FFP. So lots and lots of challenges, but we've been working on it since 2015. In 2017, I wrote a chapter in the Blue Book, Australasian Anaesthesia, about all the challenges that we faced, all the mistakes that we made, and the importance of a step-by-step algorithm, which I think turned us from epic initial failure to success very quickly when I realised that we just had to move with a step-by-step algorithm. It was too much for them to manage. But now everyone's used to it. They come through the campus, they've seen it before. We have an educational video that goes for 15 minutes that all the new staff watch, and they know that how we run it on our campus. And so it's really well embraced. And we're starting to do some research around it, had a couple of posters presented and one in the prize session. And so we're starting to audit our algorithm, look at how correcting fibrinogen can actually often fix everything else as well. The haematologists are always banging on about the platelets and the fibrinogen and how they dance together. And if one of them's really strong, it can make up for the other partner being a little bit weak in that area. And certainly by going with fibrinogen first, that often makes up for it, and you don't need all those platelets that you thought you needed.
And have you seen any change in your blood product usage from this
So
program?
in 2017, we published our blood product usage from pre and post implementation, and it came down significantly. It's a while ago that I published that now, but very significantly. Particularly in terms of FFP, which is now almost at zero, was only given if there's actually a prolonged extem clotting time or INR in that situation, and it's nearly always normalised by treating with fibrinogen or cryo and by using platelets. Yeah, so it really has changed the way that we do things and reduced our utilisation, and we did a cost assessment, and we're actually doing all of that again now.
Great, okay. So that would be interesting to see how that compares in that, 7-8 year period, you said, 2017?
Yes, so by the time it's all finished, it'll be a 10-year period.
Right, brilliant.
Oh, wow. Yeah. And then the other thing we're looking at is the preoperative testing you mentioned. We've got the multiplate machine, so looking at timing of surgery. We've implemented during COVID when they stole our cardiac surgical ward, we implemented an algorithm, me with the haematologists from the COAG lab, in terms of when to proceed for surgery. Even if someone's been on clopidogrel in the last 5 days, we couldn't have them all sitting on the ward because we didn't have enough beds. So we implemented an algorithm to proceed to theatre early if they were a clopidogrel non-responder, which about a third of people are, tying into the genetic concept. And we're now doing some studies into that. Actually, that's tomorrow morning's meeting, presenting the confidence intervals on those patients compared to background patients who've stopped their clopidogrel.
We'll be there to listen. It'll be great. So Matt and I were in another great session at the workshop day about how to publish in the medical literature. We had some great talks, and then I gave a talk about authorship, and then we had roundtable discussions, and we were on different tables, I think. Matt, what did they discuss, the emerging leaders on your table?
There were some really motivated, really keen early career researchers there, and most of the questions there were about how to get started sensibly. How do you put a foot in the door? And I think probably for a lot of society, certainly the RCOA and I guess the ASA here, that need to support early career researchers to get them going. Because I always think research is a bit like smoking. if someone gives you a cigarette for free at the start, before you know it, it's a lifelong habit. And
I think you need to work on another analogy there, Matt.
So a lot of those questions were about trying to tease out the right avenues to pursue. I mean, modern training's short, time is precious, and about not pursuing blind alleys about where you need to go. And I think they were surprised how helpful some of the editors were in terms of being approachable, in terms of, ask them questions, send them emails, ask about study ideas. It's a lot quicker to get things right at the start with a quick question to say, look, this is what we're thinking about. Do you think this is a good outcome? Is this a study you would want to publish in the future? Journal editors want to publish. We want good studies, and it's much better to get something right at the start by helping than it is to read something come in and go, this could have been so good. It's just a pity that things went wrong at the start. So I think it was a really, really useful session just to break down some of the barriers, and that's remove. I think it always feels like there's quite a lot of hierarchy in academia, and I think it was good for them to come and meet all sorts of people and to prove that academics are quite friendly, really.
I think so. I think we're friendly.
Yeah, I do too.
I got asked, because I gave a talk about authorship, I got asked some curly authorship questions, and it's particularly difficult for emerging researchers to deal with requests for authorship from senior colleagues or surgeons, people who are helping them with their research, and particularly if those people come in midway through the project. And so we discussed the need to sort that all out right at the beginning, before you write the protocol, before you put the grants and the ethics submissions in, so that you've got rules in place, and and you can say, well, look, we'd love to have you as an author, but it's precluded in our protocol.
Yeah, no, it was the first time. I hadn't come across that before on my grant, and that was one thing I took away from your talk, was what a really sensible thing to get it set in stone right at the beginning, and then it's clear, transparent, and everyone knows all the rules of engagement. Oh, that was an excellent plan.
What issues have you had at the journal Anaesthesia with authorship in recent months?
I think again, coming back to the early career researchers, I think there's an onus on the editors to allow us to publish and PubMed and give sort of PubMed tags to all our collaborative groups. So I mean, the Australian New Zealand Society has done incredible multi-centre research. I think it's one of the strongest units in the world for these large multi-centre studies. And often you might have 3,000, 5,000 collaborators. Those people's work needs to be acknowledged, and journals do need to be flexible in saying, we can have an authorship list, but then within that collaborative trials group, these people need to be identified, because without them, the work wouldn't be done. They need that recognition for future grants, for CV, for future job applications. And there has been a little bit of pushback from some centres saying you can't have this many PubMed tagged authors,
one more
but I 100% think you can and you should. And again, let's get these people involved. Let's recognise the significant contribution they make to these big studies.
Have you ever encountered any of the new types of fraud with authorship at Anaesthesia? There's one where people sell authorship on papers.
I mean, as editor-in-chief, I get 1 or 2 a month offers of a gifted authorship, presumably because they think that if I'm parachuted in, then it will mysteriously get published. They obviously haven't met my other senior editors, who would probably reject my work out of hand anyway. So I think that certainly does exist. We're always very concerned about changes to authorship after provisional accept. A new author suddenly arrives, and then that does make us scratch our head, and that's a difficult one to manage, because, well, why wasn't this person on the initial one? It's an unusual oversight to suddenly forget someone who would meet the criteria for authorship. And even when you then communicate that decision to all the other co-authors, are they people who are being browbeaten into accepting this? it's food for thought, and perhaps the solution to say actually post-submission we won't accept changes to authors. This is something you should get right at the front door, and that's probably a more sensible way around to approach this.
Along with spelling the name of the editor-in-chief correctly in your cover letter.
That's always a favourite.
Dear Professor Hemmings.
Always try to cut and paste the right editor-in-chief in for a resubmit. It does help.
I think it's a really good point you make about the journals really supporting this authorship issue, though, because, increasingly in the UK specifically, but I'm sure it's the same around the world, but our residents are really, really struggling at the moment to get on to specialist training programmes. Every point on the applications count, and some of them are putting a lot of work in to get that recognition out there, doing really good projects, really good work, and I find it quite upsetting to think that some journals aren't really supporting that. I'm not bringing anaesthesia into this, you clearly are, but I think that's it's a really, really important point that, for people that are making that first step, we should really be encouraging them to take them on the way. And I don't know if you found that with some of your projects in Sydney at all, Catherine, but are people able to take that next step with the work you've done and bring it to meetings like this and get it recognised, or is that a really significant challenge?
I think we're able to. We try and submit them, try and be involved with the university and have things checked statistically and designed well from the beginning.
Yeah.
But certainly we've got a few here as posters at the ASM, and trying to find some time and get a good group set up to proceed with some more.
And who's presenting those posters? Is it yourself? Or
So we had... I make them talk.
Perfect.
So I've got one of our registrars, Sherman, and one of our fellows, Austin. They've both actually presented now and done a wonderful job. In fact, you thought I was never going to stop clapping.
You were the most enthusiastic supervisor I've ever seen. I would have felt very well supported by your cheering.
Very proud.
But I think it's, for those listening at home, I think it is really worth saying, put the effort in, give it a go, submit the work you've done, and I think most of us around here would all say we'd be really keen to support that and see you come to a meeting like this and get the recognition for what you've done. So
Terrific. Well, we've run out of time. Once again, it's fantastic to have you all on our podcast, and I hope you've enjoyed it. We've even been videoed today, which was an added frisson to the podcast. So if you want to listen to our podcast, you can find it on our website, on our app, and on social media. We're on Facebook, X. Now we're on Blue Sky just as of yesterday, and YouTube. And we'd like to thank our sponsors, BD, GE and Solventum Australia, without whom we could not bring Top Med Talk free and open access to the world. Thanks for listening.
Top Med Talk.
Thanks for downloading Top Med Talk. Don't forget to subscribe, check us out on YouTube, and of course on social media. We're on Instagram, Facebook and X. Also, it's important to remember that Top Med Talk is the broadcasting arm of EPPOM, evidence-based perioperative medicine. We'd love you to find out more about that, and the way to do that is eppom.org. Check out our website and find out about some of the incredible conferences we're going to be arranging across the year. eppom.org.